To incorporate simulation-driven metrics, simulator-driven metrics, is a field that we now very much are looking into. We very much believe that we need to improve the metrics and to integrate them within the exam. For example, one big opportunity is that we will free up a human rating to do the more gestalt rating of leadership and other traits, rather than put a professor in anesthesiology to checklist the oxygen provision, yes or no. So a lot of it could be done from the mannequins and from the simulators. We are not doing it yet. We very much want to embark into this phase these days. Convincing other professional boards, regulators, is a big task. Not easy at all. I strongly believe that moving into simulation-based testing is a mental leapfrog. It has nothing to do with natural evolution. The decision to dive into these waters is a transformational strategic value decision. It could happen early on, it could happen later on, but it needs to have this mental leapfrog in our minds, because let's not forget that the reference point, at least at this very moment, is the fact that there's the absence of performance assessment, sound performance assessment in our testing paradigm. So whatever we do as we improve is certainly, in reference to what we do today, is better, and hopefully will be better in the future. So in conclusion, it took the OSCE movement about 30 to 40 years to mature into being accepted not only as an educational tool, but rather as a high-stakes assessment tool by regulatory bodies worldwide. I strongly believe that society will not wait another 30 years for us, healthcare professionals, to apply high-stakes performance assessment in our testing paradigm, which will include, of course, simulation-based assessment. We need to do it across professional disciplines. We need to do it at more advanced levels of practice, not only the graduate medical students. We need to do it as part of a lifelong professional development. And if we do it right, it will reflect us maturing into a much safer healthcare field. So in the spirit of our good friends from Nike, who pretty much inspired our society with their logo, we should be inspired by them on the Just Do It slogan, but we should do it right, we should learn as we move on, and we should really improve on. We need to change course. The barriers are not as high as we may think. There are barriers out there, we can cross them. It is a long way. This long way is uphill, but it's not as uphill as we might fear. And if we go that way, we will reach our ultimate goal, being leaders of a safer and more ethical healthcare environment. Thank you.
Okay, we have a few minutes for questions to Dr. Ziv, and also I would encourage you to stay in the lecture hall for the Q&A, because we're going to have the research awards immediately following. If you come to one of the microphones that are in the aisle, it would be wonderful if you could just say your name and where you're from at the beginning of your question, and we'll start with this microphone over here.
Good morning, Kyo Nihira from the University of Oklahoma. As a program director, I'm very fascinated on the naysayers because I encounter a fair amount of resistance. I'm wondering, you mentioned, for example, that 90% of the professional emergency medical technicians endorsed the process, but 10% didn't. And I'm wondering if you've explored the reactions of the people who are the naysayers.
First of all, those who didn't are a minority, but they don't have any role in making the decision. So some of them went into it not too happy, which is fine. The rest went very suspicious even initially, perhaps with a lot of anxiety, but as years went by, we now get a whole full endorsement. So I'm really not really interested in the naysayer in that respect, because this would be the raters may not want to come, that's fine, we'll have others, and the examinees have to come. But the naysayers that really interest me are the ones on the regulatory bodies. These are the naysayers that are of interest. And I really believe it's going to take us a good decade or two more, if not more, to really change generation and create an atmosphere of receptiveness. And let us face it, it's irreversible. It will happen. The question is just how long would it take?
Okay, Bill?
Amitai, wonderful talk. I'm embarrassed that we don't have a standing ovation. You've done an unbelievable job at capitalizing on a unique geopolitical situation to advance the field of simulation. To what extent can simulation succeed outside of Israel in similar ways without true top-down understanding and leadership and coupling with those that struggle in the trenches?
I think that at the end of the day, launching simulation-based testing or moving ourselves into the testing application is an opportunistic story. It really is an opportunistic story. We are in this phase at the moment. Opportunistic in the sense that we had the opportunity with Chaim sitting here in this room, courageous, red-headed leader who decided to move on and brought his friends in anesthesiology, and they did it. We failed. We have no other professional medical board that joined us yet. We have some groups out there that are doing simulation-based training of raters for oral exams at the Sim Center. Great success. We do it with ENT, with surgery. These would be, you know, small windows, side windows, by which they would eventually join us on more advanced assessment of skills. So you need a lot of patience. You need to look for the leaders. And eventually, when we'll have a critical mass, and we're getting there, I think public should be pushing us to do more. But I don't want to wait for public to push us. I really think we need to do it right, because if we wait for the public to realize that, hey, we're not doing it, I think it will be forced on us in a manner that won't be good. We need to lead it, and the more we wait, the more the chances are that we'll be led to do it in a manner that we won't be happy to.
Michael?
Amitai, again, absolutely wonderful presentation. Thank you very much. You know, to sort of start off, I'm actually, you know, a real believer that simulation, you know, based testing is in our future, and you know, will be something that you will see hopefully in the near term. Also, have watched in a variety of different evaluation circumstances where data and evaluation tools were misused and inappropriately were tied to whether competency or a variety of different outcomes. To that point, as vendors and manufacturers start incorporating more and more data and gathering data within their simulators, whatever the type of simulator, how do we actually prevent organizations, whether regulatory or not, from basically going to some extent the easy route and saying, okay, the simulator gave me this data, and I tie this to competence and to basically this person's future, and you know, really not looking, and to some extent, one of the higher order, you know, the higher order skills that we know are inherent to all of our professional lives. I'd really enjoy your comment on that, please.
Thank you for this very important question that really reflects a fear or concern out there that misuse of what we're doing in the educational arena. I'm more fearful about the educational arena being misused and not on the testing arena being misused. When you go into testing, you do it right, or you attempt to do it right, and you upfront convey the message that we're going to use this data for this application. Otherwise, it wouldn't have been a nice application. The story with education, I think, is again overly, unfoundedly, I would say, creates concern for the following reason. In aviation, when someone crashes with his airplane, the first thing you do, you go and see if the pilot has been to his or her mandated simulation exercises, training. You're not really looking at what they did. I mean, you'll go for the regulators and see how did you let this guy fly if he or she did not complete their components of training that was due. Same in medicine. I think when we'll get to the legal court, and I am very involved in the risk management and medical legal front, as you can imagine, the question will be by the court, not did you make an error? Did you make it? Because we will make errors. The question is about our attempt to avoid errors, and did we take seriously our training opportunities out there? So the very fact that an OBGYN went for training on PPH and shoulder dystocia and eclampsia and whatever, with board mandatory courses that we're running now back in Israel, and yet did a mistake in shoulder dystocia, he or she will still be able to say, I did try. But the one that didn't go there, I think is eventually going to be more in trouble. And don't forget, we don't gather the data. I mean, training is completely anonymous. Training is completely anonymous. But the assessment is not. So let us keep the anonymous. We don't provide scores in the training. We provide feedback, not scores.
Okay, and one last question to keep things moving along. The far microphone over here, Frank.
Hi, Frank Overly from Rhode Island. I'm also in awe and a big believer in all that you're doing. Can you touch upon, you mentioned your pass rates, so obviously there's failure rates as well. Whose responsibility is it for remediation, and can you just talk a little bit about the path that someone would take if they fail the test?
The standard setting of the bar, the pass rate, is an art by itself, a whole field of measurement by itself, extremely complex. And I've been with ECFMG when they decided kind of to make a pass rate in reference to the American norm data that they had. Pass rate usually starts in a more political manner than the more scientific manner, which is suggested by psychometricians. And what we did, and I've seen it done by ECFMG and National Board and MCC and others, we took the same approach for the pass rate. We went very low. We went low. It's a political decision. You want people to pass. You want people and really to find the extreme failures rather than those on the gray zone. Mostly because you do want that to be viewed. You want a few years of making sure that you are on good ground psychometrically, and that you're on good ground in terms of the political support and the professional support and beyond. And as you move on, you start to apply the standard setting psychometric models. So with nursing, they did make a decision of 60. 60 is meaningless. It means nothing. And they needed to do some decisions afterwards, yet they did fail quite a few. Those who are failed do have to take it again. In anesthesia, it will be 6 months later. In nursing, I believe it might be even 1 year later. But that means that you will not yet be a full-fledged anesthesiologist. You'll have to wait a year to come. And that's what we mean by high-stakes implications.
Okay, thank you very much. Please join me in welcoming and thanking Dr. Ziv for his wonderful presentation.